through training and teaching people about the science of addiction. So we did a series, Tess Parks, who does our Recovery Rising program, which is our advocacy work and coordinates that. We did a series of listening sessions that were funded by Maine Community Health Options, which is a nonprofit cooperative insurance company. And they gave us some funding to do these listening sessions to hear and get some data about what people experience when they go to the hospital or go to their primary care physicians or providers, and how we could impact that. And it was powerful, and people's experiences shocked me, and I didn't think I would be shocked. And it definitely drove home how much work there is to do. So out of that, we have developed palm cards about know and understand your rights. And we are about to embark on workshops with the recovery community members to teach people and help people learn how to have conversations with their providers and how to be advocates and leave behind cards when they go to the emergency room or the hospital or their primary care providers. And then we're also doing workshops with 2 of our hospitals and with 2 of our local primary care providers, one of which is our FQHC, to work with their providers and share some of what we learned, some of which is happening in their own practices, and to do that in a diplomatic way, but to help make a change. It's a lot of work to do, but we're really excited to be able to be doing it. And then the last thing before I stop is about challenges. And, you know, this morning I sat here before this meeting writing condolence letters to parents. And so I think we all know the biggest challenge is just how much this epidemic and the impact now of meth and how much this continues and how many people we're losing, even though we're doing such good work. And so I ended up putting that as my top challenge. You know, always concerns about funding. And right now we have a governor and administration that is extremely supportive and is helping these centers get funded, helping us help them financially. But, you know, that can change in an administration change. So the need to have a strong voice in Maine of advocacy and a coordinated voice, which PRCC we see as our role is to help organize that voice in Maine so that through other administrations we will be able to keep what we have and continue to build it. And then the biggest challenge, I think it's the one I've been saying since I got here, is it's still stigma, because everything falls out of the stigma that people have. So I'm happy to share, and I think I'm ending right on time. And so grateful for the work that you all do and to be part of this community, this larger community. And really, really, I said earlier, but really proud to be part of the larger work that Recovery Research Institute is doing and to be able to help with that. So thank you. Thank you for letting us be here this morning and present.
Awesome. Thank you so much, Leslie. And I loved all parts of it, you know, the inspiration of how much your RCC community in Maine has grown and reminding us of the challenges that are day to day for you guys. Thank you so much for your insight. Catherine, if you can move us to the next slide, just so that people can start thinking and doing the polling questions. We've talked about the community we're building here in terms of getting the stakeholder groups to get, you know, to really get together in the room. If we can start up, I think, so here we go. The polling question should show up. So we do ask here that you say who you are so we can keep track of if we are actually reaching folks. And then at the end, you will see some questions about today's presentation. And I will introduce our presenter in just a moment. So if you can just complete the survey, and then on the right-hand side, there's a little gray bar to scroll down. And then once you're done, you can hit the submit button. And if John gets any of these polling questions wrong, we'll highlight that, right? So there should be a button on the at the bottom, Leslie, that says submit. I think it only becomes dark blue when you've clicked everything. Is that right, Catherine and Hazel?
Yeah, so you need to answer every question and
Oh,
have to scroll to find
got
the
it.
one.
Thank you.
No worries, it's a bit complicated.
And it's also like typically in surveys, we always allow skips, but Zoom isn't quite up to par on that particular aspect. Zoom is great, but apparently for that one, you have to answer everything. How are we doing on responses?
We only have about 45% now, so I think there are a lot of questions here, so we should give it a little more time.
Yeah, I agree. Yeah, that's a scientist in me. I always want the data now. I need to learn patience better. And Steve, great comment. Actually, in a different setting, we were just talking about actually in science circles, and there was actually a discussion when I was the editor for our newsletter of Addiction Society in Psychology, and graduate students were asking, should I disclose or not disclose that I'm in recovery when I want to be trained as an addiction scientist and clinician, and how to handle that. So there's that as well. Thank you for prompting the conversation here. Yeah, that's a great point, Lynn.
Okay, so we have 85% now, so I'm gonna click end the poll now. So quickly try to submit your answers if you're still working on it. Okay. And I've just shared the results, so everyone should be able to see that now.
All right, perfect. So I will, right, I always forget that you're not seeing what I'm seeing, but I'm currently scrolling down to the responses for today's presentation, where we'll be talking about conceptual frameworks and models. Wow, you all have heard John before. Everybody's getting that question right about the two major challenges. 91% says increased vulnerability to stress, decreased capacity to feel normal levels of reward. And oh, look at that. Everybody sees lots of benefit for talking about theory and conceptual constructs in all these different ways. And I will actually, I almost clicked the help us confuse funders and reviewers, because sometimes I feel like scientists make things unnecessarily complicated to seem smart. We hope not to do that, but that is certainly something that comes to mind. So John, this room is ready for you. If we can go to the next slide, Catherine. I'm going to introduce our presenter, who really needs no introduction. All of you probably already know Dr. John Kelly. He is the Elizabeth R. Spalding Professor of Psychiatry in the field of addiction medicine at Harvard Medical School. And he is also the founder and director of the Recovery Research Institute at the Massachusetts General Hospital. And Catherine, if you would go to the next slide, Leslie already said it, but I want to repeat it here anyway. The RI is celebrating its 10-year anniversary this year. We're going to be marking the occasion in October. It's been 10 years. It's been wonderful. And I will say that John was the one who hired me 11 years ago, before the RI existed. And I absolutely absolutely love the vision he has for the RI and the mission of really taking science and not just keep science among scientists, but to get the word out, to share information, to be collaborative, to engage. And, you know, most of you know the RI bulletin, where we really break it down into, you know, the impact and the take-home messages for different groups. And I just love that. And this vision is remarkable. It's inspiring. It's part of my everyday work. And I really thank John for creating this area and this space for us. So without further ado, John, I'm going to turn it over to you for your presentation today.
Hopefully you can all hear me. Bettina,
Sure,
thanks so much. Thank you. That's very, very kind of you. Too kind, and an introduction, but very gratefully received words. Thank you for your kindness. I'm delighted to be here as always. And I just want to say some thank yous. First of all, thank you all for coming today. Thank you all for your, for those of you who've been persistently attending this series of webinars that we've put on over the last 9 months, 10 months. It's been such a pleasure. And we can all thank Bettina for that, because it's Dr. Bettina Huppner and Hazel Simpson, Katie Siegel. I don't think Katie's here today, but it's really Bettina's creativity that's and also Hazel and Katie that have created, I think, a really enriched webinar series. You know, it's gone above and beyond what is normally kind of what we normally see in these kind of things. So I've been really inspired by what Bettina's done and put together, and I'm grateful for it because it really is enriched. And as you'll see at the end here, you're going to see something at the end, which when Bettina showed me earlier, all the people that had contributed, it was really just really awesome to see all those faces. You'll see it at the end. So hang in there. If you can hang in there through my boring talk, which is intended to confuse you and make me look smart as usual, then you'll get to see all the wonderful faces of the presenters over the last year. So, but thank you. And also goodbye to Hazel, because Hazel Simpson, Hazel, give people a wave. Hazel Simpson has been just a stellar employee and contributor to this webinar series. And you can see her on the screen here. Hazel has done a phenomenal job in contributing to this whole webinar series. She's kind of in the background here, but really coordinating things as a kind of a creative force that we've been privileged to have among us for a couple of years. And she's going off to Oxford University in England to do a master's degree. So we wish Hazel well. And Hazel, thanks so much for everything. You've been incredible. And we hope to keep you in the loop somehow going forwards. All right, having said that, I'm going to try and do a fairly speedy talk here, so we've got some time for other things at the end. But thanks everybody for attending today, and as I said, for supporting the series. And we don't forget, these are all archived, so you can view these webinar videos anytime via the website. So I'm going to talk today about recovery processes and milestones, and kind of to hopefully kind of think through with you all about, you know, why things like recovery community centers, how they help people, why they are important, why we have this this grant from NIDA to build infrastructure around research to understand the impact, the public health and clinical impact on recovery of these recovery support centers, and why that might be the case. So I'm going to talk about that today. So a little bit of context quickly. You know, last year was 50 years, a 50-year milestone since the initial declaration of the war on drugs under Nixon. Now, in that last 50 years, of course, we have learned a lot. We've learned about what not to do, what doesn't work. We've learned what can help, and we're learning more all the time. We've learned a ton about the causes of addiction and how it impacts the brain, and both of those things, the genetic contribution and the impact on the neurobiology, neurophysiology of the brain. It's really helped us to destigmatize these conditions, which are still highly stigmatized, but it's helped to mitigate to some degree that stigma. has also helped us understand more about the etiology, the clinical course, as well as treatments for addiction, new treatments that have been developed over the last 50 years. Phenomenal amount of work has been produced by the National Institute of Drug Abuse and the National Institute of Alcohol Abuse and Alcoholism. In fact, 90% of the world's research and knowledge on addiction has been produced by those two institutes, courtesy of the American taxpayer over the last 50 years. And we've learned a great deal. One of the things that we have also learned and relearned and really underscored and emphasized, I think, is the notion that with the more severe and complex kinds of this disorder, that is to say, severe substance use disorder or addiction, it tends to have a chronic course. Now, happily, we've also learned that most people will find remission, sustained remission. 75%, the latest estimates have estimated that about 75% of people with a substance use disorder will eventually achieve remission, but it can take a long time, particularly those with addiction or severe substance use disorder, as highlighted in this graphic. You can see here on the left, it takes about 4 to 5 years after the onset of a substance use disorder before people will start to seek help. Now, why is that? Of course, it's the fear of discrimination. People try to keep it to themselves, don't talk about it, try to hide it because they don't want to have to admit it to themselves or others for fear of discrimination. Now, we're starting to change that, of course, but we've got a long way to go. We've made inroads, as I mentioned. What's also noteworthy when we look at the clinical course here is that after people start to seek help for these problems, it takes about 8 years in adult clinical samples, these are addicted samples in adults, about 8 years to get that first year of full sustained remission, and about 4 to 5 treatment episodes on average to achieve before people achieve that first year of full sustained remission. So that's quite a long time, of course, on average for people to achieve that. What's also noteworthy, again, from a chronic illness or chronic disease management perspective, is that it takes another 5 years before the risk of meeting criteria in the next year for an alcohol or other drug use disorder drops below 15%. Why 15%? Because 15% is the annual risk in the general population of meeting criteria for an alcohol or other drug use disorder in any given year. So to be no more likely than anybody else in the general population of meeting criteria in that year, if you've already had this disorder, takes about 5 years of continuous remission. So risk remains elevated for those first 5 years of recovery or remission, even after people have achieved that first year, difficult to achieve first year of sustained remission. Now, an obvious question that has come up is, can we speed this up? Are there things that we can do to accelerate the course into remission and stable remission? Or do we just have to wait 8 years and then another 5 years before people can achieve these milestones? And I think the answer is yes. And we are learning that the answer is yes. If we attend not just to the clinical pathology, where we devote more expensive resources necessarily, these are very critically life-saving resources for detoxification and acute stabilization. But then what's next? What's next is the question. Once we've provided that initial stabilization, acute care stabilization, detoxification, medication, in 12 weeks of treatment, which is typically the way that most of our treatments have been tested, 12 weeks of manualized psychosocial treatment or 12 weeks of medication, and we remove that and then we see what happens. This is the way that most of the research has been done in the last 50 years. And the question has become, what's next? What do we do after that? And this is where, of course, recovery support services have come into their own and really played a major role. I liken this to this whole focus in the last 50 years on this kind of war on drugs. But the focus, the concerted focus nationally and internationally on dealing with these endemic problems. I liken it to kind of a burning building metaphor, use this metaphor a lot. And you can think of it as kind of the building is on fire. We've identified the emergency. The emergency is real. We have to put the fire out. And we've done that's where we've necessarily focused a lot of our efforts. How do we put the fire out and stabilize the situation? And that's what we've done well in the last 50 years, I would argue. We know how to provide kind of short-term treatment for a chronic illness. Where we tended to drop the ball is to say, well, okay, the fire's out, but how do we prevent the fire from restarting? And also, how do we help people rebuild their lives? How do we provide the building materials that people need to rebuild their lives, and also the building permit, right? So if you think about criminal activity, criminal records related to drug and alcohol involvement, these criminal records and felony convictions can prevent people from getting a building permit. So they can't get a job, they can't get a loan, they can't get housing, they can't get the very things they need, the building materials that they need to be able to get a foothold, to get some traction in recovery. And of course, this is one of the major reasons why recovery support centers, recovery community centers have come into their own. Now, there are many parallels that can be drawn from active addiction and recovery. There are many similar processes and similar influences that influence the likelihood of addiction and also the likelihood of recovery. And you can see here the dynamics of recovery are multifactorial, just in the same way as the factors that influence addiction risk are multifactorial. They're similar but different. They're often opposing. But again, these factors change our psychosocial makeup, our social risk, and change our brain also. When we think about the social factors, which are instrumental in supporting recovery, and really, as Dr. Nora Volkov talks about now, provide the backbone of recovery, is the social factors, provide a backbone of recovery. When we think about parallels here in terms of onset and offset of addiction, we know that these social factors are very potent forces in terms of introducing people to drugs, of course, but also supporting that initial use. In fact, you think about the four main reasons why people start to use alcohol and other drugs, tends to be these four main reasons: to feel good, to feel better, to do better, performance enhancement, in other words, or because other people are doing it. And what are the four main reasons why people stop using alcohol or other drugs? Well, ironically, they're the same four reasons: to feel good, to feel better, to do better, and because other people are not doing it. So there's that 180-degree shift. What was initially the solution to my problems now becomes the problem itself, or maybe a new problem that I didn't have before. And it's the role modeling, the lived experience, the examples of the other side of addiction, which are visible, observable, for example, in recovery community centers and many other venues now, that can support and attract people and engage people in the recovery process. Now, happily, we have a much greater menu and array of these resources at our disposal these days. And, if you go back 40 years ago, 35, 40 years ago, there were very few alternatives other than 12-step. Now we have a variety, not just of mutual help organizations that can attract and engage people, but a variety of other kinds of recovery support services, including this new kid on the block, our recovery community centers. And I kind of, again, to use another metaphor, I think this is really good news. Think about fitness centers. This is another metaphor I use. So if you think about physical fitness, a question that you can ask is, do fitness centers work to keep people physically fit? And the answer is yes, of course they can keep people fit, but what do you have to do? You have to go and you have to work out. You have to go regularly and you work out, but if you do that, then you will get physically fit. So the question is not that they don't work, but how do you attract and engage people into these physical fitness centers? So they work this out. Instead of just, if you go back to your typical fitness center in 1975, it consisted of a weight room. Heavy, it was free weights. That was your fitness center in 1975. Now look what fitness centers offer. They don't just offer a weight room. Yes, weight rooms can keep people fit. There's no doubt that if you work out and pump iron, you're going to get fit, physically fit. But they know that not everybody wants to use the weight room. So they provide all kinds of classes, right? All kinds of classes, swimming pools, courts, for tennis, for racket sports, all kinds of other things that can increase the likelihood that people will be attracted and engaged into some kind of activity. that will help them become physically fit. Now, another question is, do recovery support service organizations work to keep people fit for recovery? Yes, of course they do, but again, you have to go, you have to participate. And if you do, you will become fit for recovery. This has been proven. We've got good evidence, for example, with Alcoholics Anonymous, that these things do help, but you have to go and you have to participate. And if you do, you're going to get well, you're going to get fit for recovery. Now, what we've done here is similarly to what fitness centers have done, is that we've expanded the options to attract and engage more people in the process of recovery. Providing just one option, historically, we've only had 12-step up until probably 30 or 40 years ago. Now we've got a vast variety, as I mentioned, of mutual help options on the menu, as well as other recovery support services. Again, analogously, that we can attract and engage more people into the process of recovery to help people get fit for recovery. And this is why we see this vast array. Isn't this good news? I mean, this is just really good news that we've got so many options for people, including 12-step, of course, which are highly ubiquitous. Now, why is all this important? It's important because we know, as I showed you just now, that these illnesses tend to be susceptible to relapse as people are starting to get into recovery. Can take 4 or 5 on the severe end of the spectrum, 4 or 5 attempts, serious attempts, before people achieve that first year of remission. It's kind of humorously quipped here, epitomized by this quote by Mark Twain: "Quitting is easy. I've done it dozens of times." So we know, of course, that it's not about quitting. It's how do you stay quit, right? Again, it's putting the fire out. Yes, I can put the fire out, but how do I prevent the fire from restarting? How do we as a field prevent the fire from restarting? And can we help provide the scaffolding, the building material, the building permits that people need to rebuild their life? Now, why is it that it's so difficult? And this is important when it comes to these services, because there's a neuroscience to recovery capital, including recovery support centers. Now, we're not always so aware of what's happening under the hood inside the central nervous system, but you can be absolutely certain that when people go to these recovery support centers, their brain is changing. And it's changing as virtue of detoxification, removing the toxin out of the brain, and also the social supports and social factors which influence these two vulnerabilities in a very potent way. They help to mitigate both of these pathways to relapse, that is increased sensitivity to stress, these post-acute withdrawal phenomena, and the decreased capacity to experience normal levels of reward. This happens in the brain as a natural consequence of overexposure to these overly potent reinforcing drugs, which can produce downregulation in the brain. And I kind of think about this, these aspects in terms of the environmental conditions which need to be in place. Again, there's only so much we can do in our clinical settings to help people recover at any given time. Yes, we can detoxify, we can stabilize acutely, and we can discharge. But then what? What happens then? This is where the environment is so key, the recovery environment. And this is why there's been this amplified talk of social determinants of health and other factors that can provide the right soil, the right ingredients for people to recover. Now, when we think about how organisms recover, think about a plant, first of all. Now, a plant can get sick and die if it doesn't have the right light, doesn't have the right amount of water, doesn't have the right soil and the right nutrients and fertilizer. And you can think about that as kind of the photosynthesis that a plant needs to be able to not just survive, but thrive and look resilient. You know, we all know the difference between a plant, a healthy looking plant, and one that's not that healthy. And the healthy looking one is more resilient to decay and disease. And you think about recovery, you know, when we provide the right conditions for recovery, there's a kind of a psychosynthesis rather than a photosynthesis that goes on, provided that we can provide the right kinds of conditions that are conducive and supportive for the human organism to not just get well, but also to thrive. And I think these components featured here are the SANER components, what I call the SANER components. These are, the SANER is an acronym for social, activity, nutrition, and emotion regulation. You can see those depicted here. Now, these 4 components, I think, are captured in many of our recovery support service emphases and activities they provide that strong social supportive environment that can facilitate psychosynthesis. Activity, that can be physical activity, as well as employment, education, other kinds of activities that again can help build resilience and recovery capital. Nutrition, very important, not just eating regularly, which often goes by the wayside when people are in the throes of addiction, but also the right kinds of nutrients that can help support resilience and physical health. And also emotion regulation. Of course, we have a number of treatments that are designed to address that acutely, but also the things that people do in recovery, mutual aid groups and others, also about how to regulate emotion better to prevent relapse. So all of these components, I think, are very important when we think about recovery, and they produce this nice acronym, or SANE, or saner approach to recovery and psychosynthesis. It's also, I think, very important, I'll end with this, is that we think about the milestones. And this is, I think, is important for understanding not just the processes of recovery, but who needs what, when, at what intensity, for how long, who needs what kind of service, at what intensity, for how long. And I think, therefore, these milestones become more important for us to think about who needs, particularly with the when. But as I'll show you, there's also a who. In other words, who are the subgroups of individuals who might need more and different kinds of services, and when do they need those, at what intensity, for what duration. And so there's some preliminary milestones here delineated. Most of these have been derived from our remission framework, from the medical literature on remission, from the Diagnostic and Statistical Manual. But I think we've now got some empirical data to support some of these ideas. There's an initial phase in the first 3 months, again, that where we focus most of our efforts necessarily. Got to put the fire out, got to get people stabilized before you can do anything else. Then there's this early period of recovery, 4 to 12 months, a sustained period of 1 to 5 years, and then a so-called stable period of 5 or more years. And again, that's where I showed you that's where the risk drops to no greater than the rest of the general population. So who needs what, when in their recovery, at what duration, and what intensity? Now, are you seeing that blue line down the, you see, okay, so I don't know where it's come from, but anyway, we've got a blue line down the side. That is not, I don't know how that happened. I must have done that inadvertently. Anyway, ignore the blue vertical line there. That's just a scribbling. I was scribbling there or doing something. But if you take a look at this graph, what this graph shows is the trajectory of different indices of quality of life, functioning, self-esteem, happiness, and decreases in psychological distress over time in the first 40 years of recovery. These are data from our national recovery study based on a nationally representative sample of the US adult population. But these are people in recovery who report resolving a significant drug or alcohol problem. And as you can see here, very hopefully and nicely, we're seeing these, initially steeper inclines in the benefits of recovery in terms of improvements in self-esteem, in recovery capital, in happiness, quality of life and functioning, and similarly, nice decreases year over year with a steeper incline in that first 5 years that occurs as people get into recovery. So that's good news. It's something that we can talk about to hopefully inspire others that things get better in recovery, even controlling for age year on year, because people tend to get, believe it or not, get happier as you get older. And even when you control for that, you still see this year on year increase, incremental increase in these indices of better quality of life and functioning and self-esteem. Now, having said that, again, that's a general picture using a 40-year temporal horizon. So we're zooming out there and looking at the big picture of 40 years. What about when we zoom in a little bit and look at different subgroups? Here's looking at different primary substances. And what we see here, which is really interesting, is that it's not the same for everybody. So there are different courses for different folks. And when we average, as I did in the prior graph I showed you, they would just average across everybody. But when you cut the pie a little differently, you look at different primary substances, different racial ethnic minorities, sexual minority status, etc., we start to see different patterns occur, particularly in the early phases. And this graph really highlights disparities here between people who have a primary substance of opioids and stimulants. Look at the right-hand side, you can see it takes about 2 to 3 years for people with opioid or stimulant use disorders to reach the same level of recovery capital and quality of life, excuse me, as people with primary alcohol and cannabis use disorder. There is a distinct disadvantage early on in terms of quality of life and recovery capital. So what does this do? This highlights and elucidates, doesn't it, the fact that there are certain subgroups that may be identified by their primary substance who are more marginalized, more stigmatized, who need different kinds and more of different kinds of resources that can help them achieve the same level of quality of life and functioning as others. Now, not to say that the other people are doing well, they're not, but of course it gets better over time overall. Racial ethnic groups, again, looking at cutting the pie this way, how are people doing when we pass it out by racial ethnic identity? Now, in particular here, what we see is a huge disparity in terms of American Indian, Alaska Native. That particular group tends to have a big challenge, despite being in recovery, still suffering from other detriments in terms of quality of life and functioning over time in these early years. Again, helping us to pay attention to who needs what, when, for what duration, at what intensity. We've also looked at sexual minority status. Look at the disparities here. Again, people who are gay, bisexual, compared to heterosexual individuals, big differences across time here. Look at self-esteem, for example, despite being 40 years in recovery, seeing that distinct disadvantage for sexual minority status compared to the sexual majority for people in recovery. So what does this suggest? Again, it highlights certain subgroups regarding the who needs what, and helps us to pinpoint what some people may need and what we can do better to serve those individuals more adeptly. Another thing is when, right? Who needs what, when? And this is, I think, for me anyway, one of the most intriguing findings in the recovery study that we did was just noticing this dip in the second half of the first year of recovery. So this is zooming in now to the first couple of years. So I showed you that 40-year horizon earlier. Here we're just looking at the first 2 years of recovery, okay? So look on the right-hand side here, and you can see after an initial period of stability, there is a kind of a drop. What's happening there in the second half of the first year as people are in recovery? Now, I think what might be happening here is that after this initial period of convalescence where people are getting treatment, detox, stabilization, maybe a lot of support from family and friends saying, good job, you've done well. And then as people are starting to stabilize, that support is withdrawn. And also what may happen is that the person, as the smoke clears out of the building, they start to be able to appraise the damage. So they look around them and say, well, look what I've got to clear up. And they look forwards and they say, look what I've got to make up. And those two thoughts, that dawning of reality, as I referred to it, kind of a dawning of reality, the appraisal of the damage can be a disillusioning phase of recovery in that first year. And maybe that is what is being reflected here. Now, the good news is after that first year, you can see that those indices start to go up again. So I think we're starting to, understand a dynamic course of recovery and some of the challenges and barriers inherent maybe in these different phases, dynamic phases of recovery. Initially, there may be this period of convalescence where there's a lot of support, a lot of attention. There may be treatment that produces that initial stability. In other words, the fire is out. When the smoke clears out of the building in the next phase after that, there can be a dawning of reality, which can lead to this paradoxical distress. So there's kind of a rude awakening where people suddenly realize, or they start to realize, look what I've got to clear up, look what I've got to make up. Now, if people have access at that point to the building materials and the building permit, this can lead to an industrial resolution. Bettina's smiling because she knows I love puns. So But the point here is industrial resolution. That means the resolve to get busy. I need to clear up some stuff. I need to get busy in my life and move forwards to catch up. And there's often that feeling when people are in recovery in those early, that I need to clear up and I need to make up stuff. And that industrial resolution, provided they have access to these building materials and the building permit, they're able to climb up that next phase of the slope in recovery and then achieve that, what we know right now anyway, and there's more to be for sure to be figured out in terms of the course of recovery and what the blips and potholes may be along the path of recovery and for who. But this period of conservation and growth, which we see at the macro level, where people in general are starting to improve year on year and can take action, corrective, preventative, or risk-based maintenance to help them maintain that over time. And so I think when we think about models of recovery, and this is a nice study done by Mary Leamy, published several years ago, documenting what people in recovery from mental health disorders describe as being the active ingredients of recovery. I think, one of the very important ones here is the notion of hope and optimism. We've got to give people hope and optimism that it's going to that people can get well. And I think that blip right there, where people need a lot of encouragement during that time, that if you can get to the end of that first year, get access to these building materials, you can help people have more hope and optimism for the future, because that is a time, that second half of the first year, after that initial stabilization period, where people can become easily disillusioned. So I think that's important. What I've done here, I don't have time to go into this, but is to delineate kind of this notion across multiple dimensions: biological, psychological, social dimensions of recovery. And down the left-hand column there, you can see these different phases or stages of recovery. I'm happy to share these with you. I'd love your feedback on them. But the idea here is to kind of see if we can create, all models are wrong, some are useful. The point here is to try and give us something to chew on, to think, how can we improve this? To what degree is this true? We're getting some clues as to what's happening for people as they embark on recovery, what some of the challenges are, at what milestones, and for whom. And so that is the point here. So with that, I'm going to thank you all for listening. And maybe we've got time for just one or two questions before I hand it back to Bettina, because Bettina's got some nice, a nice ending for us today, as I mentioned earlier. So if you have any, just one or two thoughts or questions, I'd be happy to take them before I hand it over to Bettina. Thanks, everybody.
Thank you, John. And I will say in the chat, you didn't have a chance to read it yet, but you will afterwards. It's recorded and we'll look for it always. There's lots of comments about how nice it is to see science backing it up and providing for renewance. There's other things that I highlight that should also be talked about in these models. So lots of excitement in the chat for you, John. Thank you.
Great. Well, listen, everybody, I think you can get these slides, have these slides, and then feel free to email us if you have questions or want papers that pertain to the slides. We'll supply those to you. And again, just thank you so much for having me once again on the series here. I'm delighted always to present and be a part of it. And I'll hand it over to you, Bettina, to close up. Thanks, everybody. Happy summer.
Cool, thank you. So Wayne, what's going to happen is for everybody who was registered, we'll be sending out an email as soon as the video recording is available online. So we put the video recording online, we put the slides online, and we put any kind of supporting documentations there as well for you to download. And Leslie, actually, if you can ask the people who gave quotes would be willing to share those quotes, I would love to put a Word document of those quotes right next to your live feature. That'd be fabulous. They were great quotes and inspiring. So that will be available. They send an email out, and of course you can also just go directly to the website. Catherine, Hazel, if one of you guys can put the link here so people know where to go to find the audio recording, that would be lovely. All right, and then Catherine, if you can screen share the last stuffs that we have here. So as we mentioned, we're going to be going on summer break, and we had some time to prepare for this seminar and to think about where our journey has taken us. And we just wanted to say a big, big thank you to everybody in the room today, to everybody who has completed a survey, for everybody who has reached out. If you can go to the next slide, actually, to just kind of show some of the faces. These are our presenters. You know, these presenters talked with us about what they will say in the seminar. They chatted with us about our ideas. They gave us directions for next topics to tackle and how we might do it. And beyond these people who have interacted, you know, vividly, that you all got to see them in the seminar series, there's others who email us and who reach out, and we so very much appreciate this participation. It's inspiring, it's motivating, it's energizing. What we're proposing to do is hard, right? We're trying to get multiple stakeholders together to talk about how do we advance the science together so that we can document, we can advocate, we can support all the wonderful work in the field that you're all doing. And it takes extra effort, it takes extra time to make space and room for science. And so many of you are engaging in that conversation with us, contributing data, moving us forward. And huge, huge thank you to you all. We so very much appreciate and are energized by it every day. Catherine, if you could go back to the next slide. We are coming back in the fall. We are going to be sharing results from a nationwide survey we've been plugging for forever at this point, which we're very excited to share with you all. And then we'll write it up as a science paper so you guys can cite it as you write your own things. And we'll be very excited about that. We will also be checking in with our pilot studies that are funded. They will either show results or more importantly, potentially the progress of how they got where they are and how they even conceptualized. Because forming these teams, right, between, you know, RCCs and scientists and, you know, putting it all together and moving forward, it's not an easy thing, and there's always hiccups along the way. So we are hoping that our pilot study groups can kind of share their process with us, because sharing process is important. Leslie mentioned about how they're onboarding so many RCCs in Maine, and it helps to have a roadmap, but it helps to have somebody who can, you know, listen and guide. And we're hoping to do that here. And if you have ideas for us about how we can partner better, help better, support better, to provide guidance of how to collect data and how to write them up and how to do science in your space, that's what we are here for. We are always all ears, happy to jump on Zoom, happy to converse via email. We are here for you, and we so enjoy all the engagement we're getting from you all. And with that, I just want to wish you all a happy and relaxing summer, and we're excited to see you all again in the fall.
Thanks, everybody. Thanks, Bettina.
Thanks all.
Thank you.
Bye.
Good to see you all.
Have a great weekend.